Thank you, everybody, for your patience. We're a little bit late in starting today, but we had a few little technical glitches, but we are here now and we are live. So I hope that you've stayed with us. I want to welcome you to the first of our 2021 PBC Facebook Live events. My name is Gail Wright, and I'm president of the Canadian PBC Society, a support group for people with PBC and their families. Our group is a registered charity completely run by volunteers, many of whom have PBC like me. And I would like to thank all of you who have made generous donations that support all of our educational programs throughout the year. And I would like to recognize our series sponsors, Intercept Pharmaceutical and CymaBay Therapeutics. Tonight, we're privileged to have Dr. Gideon Hirschfield as our guest speaker. Dr. Hirschfield holds the inaugural Lily and Terry Horner Chair in Autoimmune Liver Disease at the University of Toronto, and he is a highly regarded PBC clinician, researcher, and educator. Many of you already know him as an outstanding PBC patient educator. So let's get started on our first topic that is concerning to all of us, COVID-19 and COVID-19 vaccines. Welcome, Gideon.
Thank you, Gail, and thank you for everyone's patience as our amazing tech people sorted out the technology, which is far beyond myself and Gail.
Okay, so we have a first, whoa, I just lost my computer there. Okay, I'm so excited that we're live. I have a first group of questions on COVID and PBC, and I'll just give you the questions and you can sort of take it where you want.
Yeah.
So can PBC patients get COVID more easily than the general population? And if PBC patients get COVID, is it going to be more severe disease than the general population? And what does the term immunosuppressed mean? And are people with autoimmune liver disease considered immunosuppressed?
So I think they're all really, really good questions. I think that we've learned a lot about COVID over the last year. It's a pandemic that we've all sort of had to live and learn through. And I think what we've learned is very reassuring from a PBC perspective and also from an autoimmune liver disease perspective. So first of all, I don't believe that having PBC is a specific risk factor for you developing COVID. I think what we've learned, unfortunately, is that the people who get very sick with COVID are based around age, gender, and what we call comorbidities, diabetes, hypertension, obesity, and they really drive a very large factor. And actually, I saw a very interesting graph. Age is the strongest predictor of doing badly with COVID. So what we've learned is, and we certainly now have had some patients with autoimmune liver disease in Canada get COVID, fortunately not as many as in the US or in UK, for example, is that our patients are not more likely to catch it or do badly with COVID. And really, the group of patients we are most concerned about are patients with very advanced liver disease, particularly those patients waiting for a liver transplant, or those patients perhaps in the first 6 to 9 months after a liver transplant. After that, whilst, there may be some individual factors, largely speaking, your PBC is not an issue. And, you shouldn't be more worried than other people. You should be sensible because nobody wants to get COVID. For many of us, we can take precautions. That is not easy for everybody. A lot of the risk about how you acquire COVID is social. It will be related to the job that you do. It will be related to where you live, whether you live with a multi-generational household. So to be fair to yourself, remember there are limitations to what you can change. If your job means that you're working with 25 people every day, well then that's your job, isn't it? And that's your biggest risk factor. But PBC per se, I'm pleased to say, is not proven to be a major issue. And to answer your question about what is immunocompromised, that's quite a complex question. Our patients with PBC are not usually considered immunocompromised. We don't normally use steroids unless there's a good reason to. And although the immune system in PBC is clearly tweaked and is clearly focused against the small bile ducts, overall, our patients with PBC have got very good immune systems and they don't have more infections per se generally. So I wouldn't classify uniformly patients with PBC as immunocompromised. You know, the group where we're just that little bit more cautious is once you get to have significant cirrhosis, then it's not your PBC, but cirrhosis for everybody does lower your immune system.
Okay, and one of the questions that's coming through is about overlap syndrome. And can you maybe explain what that is and how it will differ for people with overlap?
So first and foremost, I don't think it differs hugely for patients with overlap. If I just sort of answer that question in a slightly tangential way, again, when people, particularly in Europe, have looked at patients with autoimmune hepatitis, and that's what people think about when they talk about overlap, PBC and autoimmune hepatitis, and then the use of steroids, essentially. Again, it's been very reassuring that patients with autoimmune hepatitis have not done seemingly worse with COVID in the broadest sense. And the risk factors for who does badly with COVID in a population of autoimmune hepatitis patients relates to, again, your age, your gender, and your other medical risk factors. It is true that, broadly speaking, if you are heavily immunocompromised, which is not normally the case for autoimmune hepatitis, where you are modestly immunocompromised, if you are heavily immunocompromised, then quite clearly any viral pneumonia is an unwelcome clinical challenge. And if you go into any illness with more frailty, because you're heavily immunocompromised, that adds challenges to your recovery. But again, I would like to reassure patients, broadly speaking, that they are not at undue risk and they need to take the same careful approach to preventing getting COVID, but that's just being sensible. That is social distancing, that is mask wearing, that is not having people over to your house, that is not going out unnecessary, that's following the stay-at-home rules, whilst particularly in Ontario, that's our current sort of guidance. You know, but it's not, I don't believe it needs to be draconian. I think it doesn't, there's no evidence that you need to do more than other people.
Okay, and we have another question that just came through on Facebook. That is, what about post-transplant patients?
So some post-transplant patients have got COVID. The transplant unit at Toronto General has been looking after post-transplant patients. I can tell you that in the centre in Toronto, the majority of patients who ran into problems were lung transplant patients and kidney transplant patients. There were only a few liver transplant patients. There were some patients who became very sick, but it looked like most of those patients, again, the risk factor for getting very sick was, in fact, that they were quite long after their transplant, and the risk factor was more age. Remember, post-liver transplant, often you're on very little immunosuppression. It's one of the clever things of the liver that compared to a lung transplant or a kidney transplant patient, we don't use very much immunosuppression. You're often on just tacrolimus. I think that in the very early stages post-transplant, the first 6 to 12 months, when everything is so-called bedding in, then I agree that is not a good time to be getting any viral pneumonia. And I think those patients lucky enough to get a transplant during COVID, I think are obviously taking great care during the first sort of, post-transplant months.
Okay, and have you noticed that there are less transplants in general being performed during COVID, or about the same number?
In total, I think the transplant program has had a bumper year in Ontario. I'll be honest, that's not the same in other countries, but in Ontario, we've never hit the crisis point in healthcare that, say, the UK has, where the entire health service was COVID. There was literally nothing else going on for a few weeks. But actually, the Toronto program, my understanding from Les Lilly, who keeps the numbers, has done pretty well. There has been a smaller number of what we call deceased donor transplants and more live donor transplants, but it seems to be sorting itself out. And I think he told me they did nearly over 17 transplants in January, so it's very good.
Wow, it's amazing. Okay, so I'm going to move now into COVID vaccines. This has been, I've had two types of questions. One is, I want to get it, but the government where I live seems to not want to give it to me.
Yeah.
Or I don't want to get it because I don't believe it's safe. So now those are two issues that we'd like to address. But before we get to COVID vaccines, I actually want to ask you more about vaccines in general. So for instance, last year we were encouraged, and I got my flu shot. I think I've had the shingles shot, the vaccine. In the past, when I've traveled, I've had travel vaccines. Is there any special instructions for people with PBC regarding general vaccinations?
Generally not. Most patients with PBC are not on steroids. Therefore, most vaccines are acceptable to most patients with PBC. Broadly speaking, patients who are on steroids may be recommended to avoid some live vaccines, but that can be dealt with on an individual vaccine by vaccine case. Largely speaking, you know, as you may not be surprised, we are pro-vaccine. We believe that prevention is better than cure. We believe that vaccines have been revolutionary over the last 100 years in changing the outcome for patients living with measles, mumps, rubella, diseases that you just don't see anymore, polio, in saving lives of elderly patients living in nursing homes from influenza. I mean, we already knew that if you vaccinated all the nurses who work in a nursing care home, less elderly patients die of influenza in that care home. And that's long-standing. So basically, PBC patients are generally okay for vaccines. Again, there are some nuances where, you know, you might need to get a little bit of detail, like as you approach the need for a liver transplant, although that's infrequent for our PBC patients, are still relevant to some. As you know, after a liver transplant, there'll be some adjustment because you're on immunosuppression. But I mean, largely speaking, vaccines have been very successful. And I think patients with PBC have benefited from vaccination. As you just said, our goal is that if you live with PBC, you should live a full life. So the fact that you're coming to me to say you're going to travel the world, okay, I realize that's a pre-COVID thing and we're all desperate to get back to that, but that tells me that you are living with a chronic disease successfully, and the disease is not defining you, you are defining what you want around the disease.
Okay, so we're jumping ahead a little bit, but we have a question on Facebook. Are COVID vaccines in general less effective in people with autoimmune diseases?
Okay, so the simple answer is we don't think so. The more long answer is, of course, we have to find out. Okay, these are new vaccines. In the data that we've seen to date, they are highly effective. So if you look at Israel, where there's been an amazing vaccine program, you know, the Pfizer vaccine is standing the test of the data that came from the clinical trials. Very, very high effectivity. The data that we have from the clinical trials of the vaccines, Pfizer, Moderna, AstraZeneca, remember, they are already better than most flu vaccines that you get every year, which already only work at around 50, 60% efficacy. And the next thing is, you know, what you really want from a vaccine is, of course, you might want perfection. But if a vaccine turns COVID into a mild respiratory illness that never leads to you going to hospital, that is a great success, because it saved your life. And the fact that you still got some symptoms is not really, you know, it's irritating, but it's not the end of the world. So I would say that the vaccine story for COVID is amazing, that the vaccines, that the data is looking very promising. There are studies ongoing to try and get every different subgroup that you can think of: autoimmune patients, patients on steroids, patients post-transplant, young patients, old patients, patients of different heritages, you know, to really get the data to say, does it work in every subgroup? You can imagine that, you know, we don't have time to wait for all of those studies. The world cannot stay locked down waiting to get all the perfect answers. What I can say is that there's no reason to believe, and the early safety data is phenomenal, that these vaccines are anything other than highly effective and very safe. And again, the Pfizer data has been borne out, and the reaction rate, the side effect rate of reactions is incredibly low. There will be some very rare events, 1 in a million. It's bound to happen. It is bound to be over publicized by the media, who are trying to fill every page with COVID. Okay. But I think you need to take it in perspective. Remember, every day at the moment in the UK, over 500,000 people are being vaccinated. Every day in America, more than 1 million people are being vaccinated. Remember, in Israel, they've nearly vaccinated, I think, more than 30% of the population already. Okay. And they are not seeing, you know, major side effects. And and the countries that are furthest ahead are starting to see benefit of vaccination. You're going to have to put your trust in science as we find a new way to live with what will become a virus that won't go away. This virus enters animal reservoirs. So, you know, COVID is going to be here, but, you know, we've got to get to a point where we just live with COVID and go back to our normal lives. None of us can live like this forever. Well, we can, but we don't want to.
Okay, so in terms of the development of the vaccine, people have mentioned to me, like, is it a live vaccine or not a live? I don't even know what, if you can.
None of the vaccines are live vaccines that you should worry about. So the Moderna and the Pfizer vaccine are what were known as mRNA vaccines, where essentially they've packaged up a message that your cell translates and makes a specific protein that your body then makes an antibody against, and that antibody is against the virus. The AstraZeneca vaccine, which has not yet been proved in Canada, uses another way to present the right sort of message to your body to make a vaccine, an antibody response using an adenovirus vector. But that adenovirus does not does not replicate, as far as I understand it. So it's not, strictly speaking, live. So they're actually using technologies that were there already. There's just been a warp speed effort. They have spent an unbelievable amount of money to move this along very quickly. But they're not using technology that they invented just in 2020. They're using technology that was all being lined up to make vaccines. And what they've done is just, you know, really compress the speed by literally spending an awful amount of money on it, which is great for us. I mean, if you can imagine, if they spent that amount of money on PBC, we would have cured it in 2020. I mean, they've literally spent billions and billions of dollars to make these vaccines.
Okay, somebody is asking, if you take a biologic med like Stelara or for Crohn's, is it fine to get the vaccine?
So look, the answer again is the current advice from our gastroenterology colleagues is yes. So if you look at the advice from the American Gastroenterology Association, from the Canadian Gastroenterology Association, from the UK Gastroenterology Association, they are recommending that when given the chance, you should get vaccinated. Of course, they're doing studies to check what your response is, because you want to know, you know, how effective has it been. No one is suggesting that we're all the same. I mean, COVID proves we're not all the same, because you can give COVID to 1,000 people today in Ontario, and only 30 of them will be admitted to hospital. You know, the other, you know, now the point about that is that that's 30 too many, but that means that the other 970, we don't quite know why they got mild disease. So of course there will be variable responses to vaccines, and we're not going to be able to answer everyone's questions for some time because there isn't enough data.
Okay, so There's been some questions about safety, and I think it's maybe good to recap like how a new drug gets approved by the FDA and the Canada Health or Health Canada, and what the phases are, phase 1, phase 2, phase 3, and how we got to where we are now, and is the process trustworthy, I guess is the question.
Yeah, I think the process is trustworthy. I think there's been some improvements in the process to make it quicker, but I don't think the FDA or Health Canada or the MHRA or the European Medicines Agency have cut any corners. What they've done is they've worked with the drug companies in parallel. So instead of saying to the drug companies, come to us when you've got everything ready, they've had essentially an open dialogue, as I understand it. I'm not involved, so I have no vested interest, but they've had an open dialogue where the company has told them what they're doing, has continually fed them information, has continually fed them data, has continually told them what the trials are going to look like. And so that's allowed them to have an ongoing review of the development of the vaccine, the trial, and the efficacy. And remember that these agencies are also interested in the manufacturing. So, as is often the case, the manufacturer doesn't get the credit, but you need to make vaccines. It is not the simplest thing in the world to make 1 million vaccines. Don't forget that actually the regulatory bodies check the factories as well. They check the processes, they check the product, they check the sterility, they check the reproducibility of each step. So I think, they've done all this before. And look, the way I would say is, look, we all see the world differently. I get that. I understand that. And that's, that won't change. But, there has been very, very, very few doctors who have not rolled up their sleeves the minute that they get the chance to get the vaccine. Okay. You could say, well, that's just how they think. Well, I think it's more than that. They, the rate of vaccine hesitancy amongst healthcare professionals is incredibly low. They see the benefit. The frustration for everyone is the pace. I genuinely hope that pace will pick up. I genuinely hope that everyone in Canada gets the chance to have a vaccine, and I genuinely hope that happens as soon as possible. Those are decisions that anyone who reads the newspaper are at a very high level, federal level, and then the provincial level. And so individual doctors and patient advocacy groups, we can advocate, but it's not in our power to solve that one. But I think everyone agrees that the sooner they get the vaccine, and the sooner they get it into people's arms, the better.
Okay. Just one more question on the COVID and the vaccine. We recently sent out, I think yesterday, an email just citing all the different organizations of gastrohepatologist experts putting out a position in supporting the vaccine. I think the American college was the American.
We're all at it. Everyone's done one.
38 pages. And I think, interestingly enough, the Toronto, the UHN one that you put out from the Toronto Centre for Liver Disease, it was part of our email. And it got like 60% of the people who opened our email opened that one. And I had listed it last. Good. But it was, I don't know why. And they didn't know when they clicked on it that it would just be one page. So interesting. I guess.
Well, we did that on purpose. It started off with European Reference Network put one on for rare liver disease, which I sort of edited for Ansgar Loza. I gave him some suggestions. Then Jordan said, oh, we should have one. And we already said yes. And Hemant, myself, Jordan, and the other staff physicians, penned it together. And we all agreed it had to be one page and to the point.
It was, and I think people did read it, and that's terrific. And it's very telling that the whole community came together within a couple of weeks to sort of produce a unified front.
I think so. Vaccine hesitancy is one of the biggest risks. Is people feel this has all happened so quickly. The news is overwhelming all the time about COVID, and at the same time you've got COVID fatigue. You don't know what to believe. And, you know, the vaccine rollout, let's face it, is not as good as it should be. So when people make difficult decisions, they go to trusted sources. And in healthcare, that's often their family doctor. You know, and I hope that vaccines are delivered through family doctors, because that allows you to feel trusted. I mean, my dad in the UK got his through his family doctor. You know, that makes it more normal, doesn't it? But I mean, that's, as I said, that's beyond our pay grade. We don't know what they're planning for Ontario. One hopes that they do go to the experts. I mean, our family doctors in Ontario, around the world, are experts in vaccinating you. It's a major part of family medicine, isn't it? And they have a trusting relationship with our patients, and we just wanted to add to that trust.
Well, I guess during COVID, you've been seeing most of your patients virtually.
So we pivoted on March the 15th, 2020. I went 100% virtual. We see anyone who's sick, anyone who needs to come in person can be seen. But largely, you know, but for our, you know, particularly for our autoimmune liver disease patients, we've seen them virtually. It's been a reasonable success, I hope. I've tried very hard to use webcams wherever possible. Sometimes that's doesn't work, so we use the telephone, which is okay. Not perfect. And we've managed to run a pretty good program, I hope. I'd like to think that actually we're more on time with clinic than we've ever been. I think anyone who comes to my clinic now if they wait more than 5 minutes for the call from me, then that's very unusual. Whereas of course before, particularly those patients who remember Jenny Heathcott and her advice, which was always to bring a book while you sat in clinic, I hope that doesn't happen actually. So I think we've been quite successful actually.
Yeah, I think so. My appointment, it doesn't even matter if it's 10 minutes late because you're at home waiting. So it's not like you've parked and you're worried. And anyway, I'm just wondering, you know, a lot of PBC patients, we have issues with fatigue, and because of that fatigue, often there's social isolation, and especially during COVID, you were talking about, you know, we're getting weary of COVID. And when you do have your virtual appointments, are you seeing any of that come through in patients who are feeling like, you know, PBC times 10?
A little bit, yes. I think it's very individual, but there are definitely, all of us, staff and patients, are fed up with this. And, you know, for some patients, they feel very isolated. We've got some data that suggests that as the pandemic goes on, particularly our younger patients with PBC are struggling a bit more with their fatigue and their social isolation, probably. So I think it's a live issue. It's very hard to know how to tackle. I think we can give you good advice about, you know, going for exercise, talking to your friends, trying to do some mindfulness, you know, but it's very difficult because I think you can't capture all the individual issues of an individual person's family life, personal life, social life, professional life. So it's quite hard to untangle PBC from all of that. And I, you know, I think it's a worry, isn't it? To you know, I think the public health doctors know that although it's very easy to say just lock down, that there is a duration of lockdown beyond which people stop listening. They simply move beyond what the government says and do what they, you know, want, because they can no longer function. I don't know what you think about that, Gail, but I just think, you know, and I think government knows that. And although it's a complex one, there's a point where everyone says, I can't live like this anymore. And so you have to be smart with lockdowns, and you have to be smart with the engagement with everybody. Otherwise people will you know, find their own solutions to coping with their quality of life.
Yes, I think so. We have a couple more questions, and I'm not going to ignore them. I'm going to save them till the end because I want to get through some other stuff as well. So this is about getting the PBC diagnosis. And I guess in this virtual care world, are you getting the same amount of referrals that you were pre-COVID, or
I
has it?
think so, yes.
Okay.
The GPs have pivoted, and today I was on service, and we got 17 referrals. There weren't any PBC amongst those. But they are still coming. Our processes are very efficient. It's all electronic. I think, and again, you might know more than I do, there's been some challenges in the community about GI officers and how they've managed during COVID. We're lucky, and it's also unlucky, but I work in a big hospital. The hospital doesn't provide me any resource to run my outpatient clinic, but we're just more structured. We have a clinic, if that makes sense.
Yeah.
I bought my secretary a laptop, and I bought her a mobile phone, and she can work from home 4 days a week. Okay, and she can access a reasonably good, not perfect, but reasonably good electronic medical record. Okay, so I was able to, although it's not been easy for her and none of her colleagues, we were able to sort of create all the structures we needed. We are a little bit worried that in the community there's been a sort of a slowing down, and maybe that means there's been some patients haven't got referred from their primary care doctor to their local gastroenterologist, etc., etc.
Mhm.
And I think that's where we rely on you guys to really keep advocating, because we are open, and any referral that we get will get a new patient appointment.
Okay. I think do you have a waiting list?
It's quite complicated.
Okay.
I try and see all autoimmune liver disease referrals within 12 weeks. We will see a real urgent autoimmune liver disease referral within the week, okay, as needed. So the answer is, we've got room, but I mean, you have to. We've talked about this before. You can't just change a system. Systems are how they are, aren't they? Healthcare is complicated. PBC is one of many diseases, and it's a journey for patients, regardless of COVID, to getting a good family doctor that listens to them, a family doctor that sends the right tests, a family doctor that recognizes. I'll tell you one thing that we're pushing really hard, but it's going to take time. Myself and one of my colleagues are very happy to do electronic consultations with family doctors, and have offered to reply to their electronic consults within 24 to 48 hours.
Nice.
But
So,
but we can't make them do it. So they have to want to do it, you see.
okay, I'm going to quote you to you. I think you've said many times, getting a clear diagnosis is one of the most important things.
I couldn't,
And
I must be right on that one. I agree.
well, now you have to expand on that, please.
Well, to me, it's about you need clarity at the beginning of the journey, don't you? How can you identify how you're being plugged into a pathway? And if you think about it, when you get any disease, essentially, you get a diagnosis, and then there's a core journey which kind of works for the majority of patients with that diagnosis. It's like a route, a route map. Okay. And if you start on the wrong route because the diagnosis is not clear, that's like driving down the freeway and not being sure when you should turn back. I mean, in fact, this happened to me. Where were we going? I was taking the kids. That's right. We were going to some Ontario National Park. My sat nav, the volume didn't turn on. I missed the turning. And I thought, well, I'm going to keep going, and I keep going. And then the journey seemed to get longer and longer and longer. And at some point I said, yeah, I'm going to turn around. I'm going to do a U-turn, and I'm just going to drive back to where I missed my turning. Okay. Now, the analogy is in medicine, if you can do the same thing, because once the physician thinks you've got something, they don't turn back until it's a bit late. And they say, gosh, it wasn't really autoimmune hepatitis at all, was it? It's actually PBC. But by that time, you've had all the autoimmune hepatitis treatment repeatedly. So I'm a big believer in clear diagnosis means plug into the correct pathway, the first line treatment, the second line treatment with Ocaliva and other off-label therapies, or or clinical trials, and it's so much easier if you start the journey and you take the right freeway. And it's so much harder if you get stuck on a set of roundabouts. You don't know what a roundabout is, Gail, but it's a UK thing.
I do. I have been there. I have been to London. I have gone in circles and circles. They have them other places too. Okay, so believing that, I believe that may have led you to develop the now famous PBC Care Pathway that is being published many times over with your name on it.
Yeah,
So,
I mean, and we've tried to. I mean, what we've tried to do there is take guidelines, which, as you kind of pointed out with the COVID vaccines, can be far too long, and just sort of graphically divide up the journey of PBC from diagnosis, first risk stratification and staging, first line treatment, does that work? Second line treatment, does that work? And just sort of segment it really. And I think you've been working on it for your website, which reminds me I need to get back to that. Where just so patients can understand where they are. Simplify it. I mean, I'm a big believer that we professionals always overcomplicate things, but in actual fact, for the majority of our patients, they are perfectly able to understand their disease and perfectly able to understand the components of the disease that are relevant to them. And I think that's the same message that I would give to patients as I give to primary care, secondary care, gastroenterology, hepatology, everyone.
okay, so that care pathway is now in several jurisdictions, if you will, right? Yeah, so it's like
and the idea of that care pathway was that it could be adapted, because as I said, you can't expect PBC to change healthcare delivery around the world in every, because that isn't logical, that's not realistic. But the idea was that people would say, okay, well, this works great in Italy, but we would do this, or in Spain, it's traditional that all patients go to a gastroenterologist, they don't go to a hepatologist. In Ontario, well, if you live downtown, urban areas, well, that's easy, but what happens if you're living in Sudbury, or you're living in rural Ontario? So you have to adapt. I hope that the adaptation of virtual medicine actually makes things easier in many respects. It really breaks down barriers, doesn't it? I mean, it's not perfect, but I can look after a patient anywhere in the province. They can go and get their Life Lab blood tests or Dynacare or wherever they want to go. The results come to me as an e-fax. I see them. I can dispense a drug, it be that urso, obeticholic acid, or anything else. I had a patient today who was part of a clinical trial. It wasn't for PBC, and I happened to have clinic with him, and he said, "Oh yeah, not to worry. The trial nurse is round at the moment taking my bloods for the clinical trial."
nice.
That's not bad, is it? He hadn't left the sofa.
I like that kind of medicine.
Well, that's the future, isn't it? Why not?
Okay, so the care pathway, back in the 80s, we used to call it a flow chart. I don't know if they still call it that, with a decision tree.
Yeah,
So
essentially.
if this happens, go this way. If it's yes, go here. If it's no, go there. So that's for the treater, the medical professional, to be following. What role do you see of the patient in that care pathway?
Well, I'd like to think that the patient understands where they are in that care pathway. I'd like to see that the patient advocates sufficiently to say, why do you think I've got PBC? You said I might have overlap. Are you sure? Why do you say that? You gave me urso. How did you choose the dose? Or how do you know the urso works? Or how long should I take the urso before I should think about the next drug? How are you going to tell me that it's now the time to consider obeticholic acid? Why are you choosing that drug? What about this approach to treating my PBC? So I hope that with the education that they get tonight, with all the stuff that you do for your charity and other PBC charities, that patients feel able to sort of corral their questions and say, essentially, what are logical questions, and they're the same questions that they would ask in any other disease, aren't they? And it's not impolite to ask questions.
Right.
It's essential, really.
Excellent. Okay, we're going to go about 5 minutes over because we started quite a few minutes
Sure.
late. So I'm going to go back to, so that was my formal questions that I had, but we have some more that were on COVID related. And one is about someone who has more advanced disease, advanced cirrhosis and variceal bleeding.
Yep.
And so would this weaken their immune system is their question.
So as I alluded to, the more advanced your cirrhosis, then yes, anyone with advanced cirrhosis has a more impaired immune system and has a greater susceptibility to infections. And, we do push, we are pushing, and we hope that Ontario, particularly like the rest of the world, will prioritize those patients for vaccination. It
So you
doesn't mean you shouldn't get
want,
the vaccine, but it highlights all the more reason why you should, in fact.
okay, that I think that's a question on people's mind is
You
if
know,
they're,
and we hope, and remember, Ontario changed their policy early on, which was good, to say that patients who do have autoimmune diseases, patients who are immunocompromised, can receive the vaccine, and that's the same advice as that's given around the world.
okay, another question coming in is if we do get COVID, what's the best thing we can do to treat it if we aren't in a hospital? I guess, and that's referring to PBC patients.
Good question. Good question. At the moment, as you know, there are no approved treatments for COVID. The advice is to stay well hydrated. The advice will be based on whether you get very significant breathlessness, and whether you need to get extra input from ER. We are not recommending anything special. We're not recommending you stop your medicines. We think you should continue your medicines. We're not recommending you stop any of your blood pressure tablets. Of course, you're going to stay linked into your family doctor and or a COVID clinic who'll be advising you. And of course, you're going to go to hospital if you're the unlucky group of patients who gets progressive symptoms, which are really around a respiratory pneumonia. There's a lot of discussion about these drugs. Hydroxychloroquine does not work. Then people talk about invermectin. Well, honestly, it's not clear. And then colchicine, I just don't believe it'll be that simple. So the drugs that have made a difference so far really is dexamethasone, and that's for patients with moderately advanced disease who are sick in hospital. And then everything else is in clinical trials. And those clinical trials will give us the answer. For the time being, if you're unlucky to get COVID, treat it like you've got flu, good nutrition, good hydration, and sensible interactions with your primary care provider.
Okay. Another question is one of the vaccines better than the other for PBC?
We don't think so, no. I mean, I think the answer will be take the vaccine that they give, that you can access. There's some excitement about the Johnson & Johnson vaccine because that's a single dose vaccine. You have it just once.
Mm-hmm.
You can imagine if you want to vaccinate 35 million people in Canada, that would be an advantage. Remember, for this to be a great success, if it prevents people being hospitalized and turns COVID into a mild respiratory illness, that's still a great success.
Okay, not COVID related, but can PBC cause breathlessness?
Very rare. I mean, there are some rare associations with PBC and some other autoimmune lung diseases. There are some rare associations where because of your advanced PBC, you get some lung problems, but largely speaking, no.
Okay, I think that's all the questions that have come in through the Facebook feed.
Great.
Is there anything that I haven't asked you that you've been dying to tell every patient who's tuning in?
No, except that we're all trying our best. I think, just remember that however COVID fatigued you feel, I think, your healthcare team feels the same, from the secretary, everyone. But I mean, actually, PBC patients have done well, and we've managed to continue treating our patients like normal. And I really hope that some of the advances in virtual medicine will be long lasting. I miss seeing patients in person, but honestly, the fact that patients are not wasting 8 hours of their day or 4 hours of their day for a 15-minute consult, we need to hold on to that, don't we? We really do.
Okay, this has been terrific. It's always a pleasure to talk to you, especially for a whole hour.
And to solve the technology. Thank you to our amazing technology people doing things that
Yeah, that was a little bit scary, but did you
two
notice
of
how
us would not understand.
I remained calm for the
Yeah.
whole thing? Were you impressed by that? I
I
just,
very, yep.
hey,
And
Sarah, Sarah, like I'm in COVID blend Zen place where if we don't do it today, perhaps we'll do it tomorrow.
exactly. And we weren't like that a year ago. I mean, now we've
No,
all had to sort of say, oh, well, this is beyond my control.
exactly, beyond our control. Anyway, thank you for everyone who joined us today. Thank you, Gideon, again, for always providing us with some great information, good conversation. And thank you again to our generous sponsors, Intercept and Sima Bay, who make these things possible for us. So until our next session will be February 24th with Dr. Mark Swain, Dr. Magnus McLeod, Dr. Andres Duarte talking about PBC fatigue. We're going to follow that with a great conversation between Dr. Aliyah Ghulam Hussein and Dr. Alan Bonder from Harvard Medical talking about PBC risk stratification treatment, second-line treatments. And then we're going to follow that with a patient panel to talk about living with PBC during COVID and just living with PBC altogether. These are three very interesting ladies. Many of you probably know them from different chat groups you're in, but they lead dynamic and diverse lives. So it should be a great evening. And we've got something lined up for April, but I'll save that announcement till later. So I'm going to sign off now, and hopefully everybody enjoyed the talk. Thank you again, Gideon.
Thank you. And I'll click leave. Thank you and
Click
good night.
leave.
Bye-bye. Bye-bye.